Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 226 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, ZXJ, an 18-month-old boy presented with 4 days of sudden onset, severe watery diarrhea, after 2 days of being nonspecifically unwell. ZXJ was passing stool approximately 15 times per day. He had vomited for 1 day, but this then stopped. There was no blood in the stool. ZXJ was also noted to have a dry cough and appeared to have coryzal symptoms. ZXJ had not had a wet nappy for 24 hours. ZXJ had stopped breastfeeding at 12 months old. On examination, he was markedly dehydrated, with a temperature of 38.5 degrees Celsius and a tachycardia. ZXJ required aggressive fluid resuscitation. So my question to you is, in addition to intravenous fluids or oral rehydration solutions, what agent would improve ZXJ's outcome? Is it A, ascorbic acid, or B, cholecalciferol, or C, magnesium, or D, thiamine, or is it E, zinc? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E, zinc. I will clarify why. This is a case of rotavirus infection. There is no specific antiviral treatment. However, zinc, given for 10 to 14 days during and after a diarrheal episode, has been shown to decrease diarrhea mortality by 23%. Additionally, vitamin A supplementation reduces all-cause diarrhea mortality by 30% in children aged 6 to 59 months. Please proceed to the next question. And the next question reads, DAW, a 25-year-old primigravida presents at 34 weeks of gestation with a 1-day history of fevers, rash, dry cough and coryzal symptoms. DAW had recently moved to the UK and was uncertain of her childhood vaccinations. On examination, DAW's temperature is 39 degrees Celsius, and a generalized maculopapular rash which is coalescent on her trunk. Some small cervical lymph nodes are palpable bilaterally. There are small white spots on the buccal membrane beside her molars. DAW has bilateral conjunctivitis. DAW is concerned about the risk to her baby. So my question to you is, what are the possible adverse effects that she should be made aware of? Is it A, cataracts, or B, hydrops fatalis, or C, intrauterine death, or D, no increased risk of fetal adverse outcome, or is it E, sensorineural deafness? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Intrauterine death. I will explain why. This is measles, as evidenced clinically by the 3 Cs, cough, coryza, and conjunctivitis, and the COMLEX spots. Measles infection in pregnancy is associated with higher rates of premature delivery and intrauterine death. Please progress to the next question. And the next question reads, GBY, an 11-month-old boy developed a high fever. This was associated with malaise, irritability and poor feeding. After 48 hours he developed a macular rash along GBY's arms and legs. There was extensive confluent blistering of the perineum, but otherwise the trunk and back were spared. There were no lesions on GBY's scalp. There were a number of perioral lesions, but no lesions visible inside the mouth. Some of the lesions progressed into thin-walled vesicles containing clear fluid. There were macules on the soles of GBY's feet. The fever resolved 24 hours after the rash appeared. The rash took 10 days to clear, but left no scars. 3 weeks later the skin on his feet began to desquamate. GBY attended a nursery for 3 days a week. GBY had had his vaccinations as per the UK schedule for his age. GBY had been born at full term and was meeting his developmental milestones. GBY lived at home with 2 older siblings. So my question to you is, what is the most likely pathogen? Is it A. adenovirus, or B. Coxsackie A6, or C. echovirus, or D. herpes simplex virus 1, or is it E. varicella zoster virus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Coxsackie A6. I will justify why. This is a case of hand, foot and mouth disease abbreviated as HMFD, most commonly caused by Coxsackie viruses A10, A6, A16 and enterovirus A71. Outbreaks are commonly associated with daycare centers amongst others and in infants and children under the age of 5. Please progress to the next question. And the next question reads, TTK, a 52-year-old woman developed an encephalopathy and was admitted to her local intensive care unit. On extensive questioning of TTK's partner, a recent travel history and the course of her illness were elicited. TTK had returned from a 3-week holiday to Bali where she had been bitten by an apparently healthy rhesus macaque. TTK had been vaccinated prior to travel with the rabies vaccine, and received 2 intramuscular rabies boosters after the event. 2 weeks later she had developed localized pain, redness and vesicular skin lesions near the site of the bite, followed by localized numbness. Ataxia and diplopia ensued with confusion, and then coma. So my question to you is, what intervention could have successfully prevented TTK's illness? Is it A. amoxicillin clavulanic acid 625 mg thrice daily for 7 days? Or B. no intervention available? Or C. rabies immunoglobulin infiltrated into the bite wound? Or D. valacyclovir 1 gram orally twice daily for 14 days? Or is it E. wound irrigation for 5 minutes with scrubbing? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. valacyclovir 1 gram orally twice daily for 14 days. I will clarify why. This is the recommended post-exposure prophylaxis for high-risk herpes B virus infection incidents. However, the low incidence of infection relative to the number of exposures can complicate the decision. Please advance to the next question. And the next question reads, EGH, a 24-year-old pregnant woman attended her GP at 14 weeks of gestation as her 2-year-old daughter had developed a rash and fever consistent with chickenpox that morning. EGH had been born and brought up in the UK. EGH was unsure of her varicella immune status. So my question to you is, what is the most appropriate management for EGH now? Is it A. Ask her to re-attend if a rash illness develops? Or B. Check her varicella zoster IgG, or C. Give her intramuscular varicella zoster immunoglobulin? Or D. Give her varicella zoster vaccine? Or is it E. Reassure her that she is likely to be immune? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Check her varicella zoster IgG. I will explain why. She may require varicella zoster immunoglobulin to reduce the risk of severe maternal disease and to reduce the risk of fetal varicella syndrome, but as it is a human product and there is time, she should have her immunity checked first, as she may be immune already. Please proceed to the next question. And the next question reads, WOK, a 21-year-old woman presented to the sexual health clinic with multiple painless lesions over her vulva and perianal area. These were skin-colored, mostly smooth papules of less than 5 mm, but with a few raised cauliflower-shaped clusters. So my question to you is, what human papillomavirus (HPV) type is most likely to have caused WOK's infection? Is it A. HPV1, or B. HPV6, or C. HPV16, or D. HPV18, or is it E. HPV45? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. HPV6. I will clarify why. HPV6 and HPV11 are the etiologic agents of genital warts which occur in sexually active individuals, and also of recurrent respiratory papillomatosis abbreviated as RRP, which may have onset in childhood or in adult life. Please proceed to the next question. And the next question reads, FTT, a 42-year-old man with polycystic kidney disease underwent cadaveric renal transplantation, cytomegalovirus donor negative Ration negative, HLA incompatible. FTT's immunosuppressive regimen consisted of tacrolimus, prednisolone and mycophenolate mofetil. He was taking trimethoprim sulfamethoxazole for PCP prophylaxis. At 10 months after the transplantation, FTT reported rose-colored urine. He was otherwise well. Urinalysis showed leukocytes +2, hematuria +3. His creatinine is 238 micromoles per liter. So my question to you is, which of the investigations listed below is most likely to be diagnostic? Is it A. Plasma for CMV-PCR, or B. Renal biopsy? Or C. Serum galactomannan? Or D. Urine cytology for decoy cells? Or is it E. Urine for BK virus PCR? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Renal biopsy. I will justify why. This is a case of BK virus nephropathy. The definitive diagnosis of BK virus nephropathy requires a renal biopsy showing polyomavirus-induced cytopathic changes in tubular or glomerular epithelial cells. Please proceed to the next question. And the next question reads, KOP, a 39-year-old woman presented with mild fever, malaise and myalgia 1 week after her 5-year-old son developed a malar rash, after a few days of fever and coryzal symptoms, as shown in the photograph below. Pause the video and carefully scrutinize the photo before advancing to the next slide. KOP was usually fit and well. KOP had an intrauterine device in situ and did not take any regular medications. KOP had no known allergies. KOP had been born and brought up in Albania and had moved to the UK at 18 years of age. KOP was concerned about the possible complications. So my question to you is, what complication is KOP most likely to develop? Is it A, aseptic meningitis, or B, chronic anemia, or C, myocarditis, or D, rheumatoid-like polyarthritis, or is it E, transient aplastic crisis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D, rheumatoid-like polyarthritis. I will justify why. Accompanying joint symptoms are rare in children but may be severe in adults, more often in women. These consist of an acute, symmetric rheumatoid-like polyarthritis which usually improves within 2 weeks but occasionally may persist for months. Please proceed to the next question. And the next question reads, QPL, a 54-year-old pet store owner presented with 4 days of fever and headache, and 2 days of a rash that had started on his face and spread outwards. On examination, QPL had a macular rash over his face and distal extremities, with only a few lesions on his abdomen and back. QPL's body temperature was 38.3 degrees Celsius. QPL had widespread lymphadenopathy. Examination of his cardiovascular, respiratory and abdominal examinations were unremarkable. QPL was admitted for observation and investigation. Over the next few days the rash evolved from macules to vesicles to pustules. The fever persisted for 8 days in total, the rash for 12 days. Electron microscopy of lesion biopsy is shown in the photograph in the next slide. Pause the video and carefully scrutinize this photo before progressing to the next slide. So my question to you is, what is the most likely pathogen? Is it A, herpes B virus, or B, monkeypox virus, or C, streptobacillus moniliformis, or D, treponema pallidum, or is it E, varicella zoster virus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B, monkeypox virus. I will clarify why. The diagnosis of monkeypox infection requires a clinical finding that is a rash, an epidemiologic finding, that is the patient hails from equatorial Africa, and laboratory findings that is the presence of genomic DNA or brick-shaped virions in scab material. Please proceed to the next question. And the next question reads, JMK, a 29-year-old man seeks medical attention on returning from a camping holiday in Germany. JMK sustained a bite wound to his left hand 4 days previously from a wild fox he had tried to feed by hand. JMK has not seen any other healthcare professionals. He is concerned about the risk of rabies. JMK has received a full course of tetanus vaccinations and the wound looks clean and dry. So my question to you reads, what intervention is required in JMK's clinical scenario? Is it A, wound debridement and washout, or B, topical povidone iodine, Or, C 5 doses of IM rabies vaccine days 0, 3, 7, 14 and 28. Or, D human rabies immunoglobulin infiltrated into the wound. Or is it E reassurance only? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E reassurance only. I will clarify why. Western Europe, including Germany, is free of rabies in terrestrial animals. As such, even though a bite that penetrates skin is high risk, the epidemiology means that rabies post-exposure prophylaxis is not warranted. If this had been a bat bite, this would not be the case. Please progress to the next question. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 227.